Good morning, everyone. We are now live.
Good morning, and welcome to this meeting of the Primary Care Access, Delivery, and Payment Task Force. I'm David Seltz, Executive Director at the Health Policy Commission. A warm welcome to all of my fellow task force members. Thank you for your time and participation this morning as we continue this important work of the task force in strengthening primary care here in Massachusetts. I also want to welcome everyone who's following on the live stream. Thank you as well for being engaged in this work. And we're looking forward to a great meeting today. Virtual meeting, but a great meeting and a lot of content to get your input and feedback on as we continue this work. But before I move any further into this meeting, I'd first like to give a very warm and heartfelt congratulations to Kiame Mahania, who has been named as Secretary of Health and Human Services by Governor Healy. I think I can speak for all of the members of this task force, Mr. Secretary, when I say that we're thrilled that you have elected to step into this role and to provide your steady leadership at a time when the Commonwealth desperately needs it and our healthcare system desperately needs it. And I'm thrilled to continue this work with you together. And also want to, of course, recognize Kate Walsh and her leadership over the past 2 years. But the governor made a great choice here, and we've got a lot of important work ahead of us. So congratulations to you, Mr. Secretary.
Thank you, David. I'm still not used to that title. Whenever somebody says that, I look for Kate Walsh around me. It's a great honor to have been nominated and to have been shown the trust to help lead this part of our government in a moment that calls for incredible amount of collaboration and also vision. And I think we were already ready through this primary care task force, but I think it also is a time that is calling on all of us to really tackle some deep problems that perhaps have been lingering for a few years or a few decades. And now we have external forces that are really forcing us to come up with solutions because keeping on the same path is not sustainable. I'll be happy to announce that even though my title changed, I'll keep co-chairing the primary care task force along with David, because I really believe that making some changes to our primary care sector is really crucial to us even beginning to address some of our other challenges. The only change that you'll see in terms of organizationally is that I've asked Dr. Ryan Schwartz to step in for me in terms of leading the sort of subcommittees, the work groups. So Dr. Ryan Schwartz will be a designee to lead or co-lead those groups. But I look forward to keeping working with you and talking with you and interacting with you on a regular basis. That being said, sometimes slight emergencies come, and so I am in Fall River today and there is a meeting with the Fall River folks at 10:30. So I'll be on for the next 20 minutes, and then I'll be leaving you in David's very capable hands. And David, I am excited to work even more closely with you and the Health Policy Commission. And so I really look forward to the next few weeks. So thank you, David. Back to you.
Thank you, Mr. Secretary. And again, I think I can speak for all the task force members where we're so appreciative that you're going to continue to be co-chairing this task force and giving part of your, really precious time to this work. And as you said, your commitment to primary care, your commitment to understanding the opportunity that we have with this work of this task force is really crucial. So looking forward to continuing this work and working with Ryan on the working groups as those move forward. So it's really great to be back together with all of you today. This is our fifth meeting of either the full task force or one of the work groups that we've had in the last 3.5 months. So again, a heartfelt thank you for your time and energy and commitment to this work. We plan to spend the agenda today really focusing on continuing to make progress on the key deliverables that were laid forth in the statutory mandate for this task force. We've been working through these different deliverables, and we'll have a proposal to share for you on deliverable number one for discussion and feedback. But really, the bulk of this meeting today is going to be discussing how we can move these forward and move to final recommendations and deliverables. But before we do that, we do have one piece of business, which is approval of the minutes from the last full task force meeting on June 17th. And so we'll first ask if there are any comments, questions, corrections to the minutes. Seeing none, I'm happy to entertain a motion to approve the minutes.
Moved.
Second.
Thank you both. And I'll turn it over to Deputy Executive Director of the HPC, Colleen Elstenmeyer, to run through the roll. And we will have to do this verbally and through the roll call because this is a virtual meeting.
Great. Thank you, David. Start with you, Mr. Secretary.
Aye.
David Seltz,
Aye.
Senator Friedman,
Aye.
Commissioner Caljo,
Aye.
Lauren Peters, Dr. Schwartz,
Aye.
Dr. Altman,
Aye.
Laura Black.
Yep, I am here.
Thank you. Jennifer Blewett,
Aye.
Allison Bracken,
Aye.
Dr. Critchlow,
Aye.
Suzanne Curry,
Aye.
Dr. Friedberg.
Aye.
Thank you. Dr. Gilchrist,
Aye.
John Hurst,
Present.
Dr. Martin,
Aye.
Dr. Mellon,
Aye.
Sarah Mills,
Aye.
Laura Pellegrini,
Aye.
Dr. Pring,
Aye.
Christina Severin,
Aye.
and Dr. Spivak.
Aye.
Okay, back to you, David.
Great. Thank you, Colleen. Thank you, everyone. So we've divided the agenda up into the first three of these statutory mandates. And so the first one is around defining primary care services, codes, and providers. We've had the opportunity to talk through this specific deliverable, both at the last full task force meeting, but also in the course of two of the data and research work group meetings. And so today we're coming to you with a draft proposal for what the final deliverable may look like. We did present a version of this at the data and research work group and got some great feedback, but want to hear from the full task force today with the goal of being able to come back at our September meeting and have final consideration of what this deliverable will look like. We'll spend also in this meeting time on the next two items, data and reporting requirements, and continue the conversation about establishing a primary care spending target. So first on our draft proposal for defining primary care services, codes, and providers, we have this draft proposal, which I'll walk through briefly with all of you and then open it up for some discussion. But as you can see on the bottom half of this slide, a rough outline of what we are proposing to incorporate within this recommendation. First would just be a brief introduction to the issue, and then the policy recommendation with some subcomponent pieces to that, and then finally a summary of the current CHIA methodology, and a list of other considerations for CHIA as they move forward in this work. Next slide. So first, the recommendation would include just an introduction highlighting the importance of measuring primary care, highlighting its value, and really emphasizing the important role of measuring primary care expenditure data in supporting data-driven policy changes, investments, and reforms, and setting improvement targets. As we've discussed at these meetings, while there's no national one consensus for how to measure primary care spending, nearly 20 states have adopted some methodology, and many of them do so in roughly the same structure and fashion, by defining primary care providers, defining primary care services and settings, and using billing codes to be able to build up expenditure data from health plans. Next slide. So, building off of the highly credible and robust process that we already have here in Massachusetts that CHIA has really been the leader on, the draft recommendation would recommend that we continue to have CHIA be the agency responsible for ultimately defining and measuring primary care spending as they are doing so today. And with that recommendation, we would have we are proposing a number of sub-recommendations to further highlight some of the principles that this task force has discussed. So on the next slide, you can see 3 of those sub-recommendations to this recommendation. First is that the legislature should codify CHIA as the agency responsible for doing this work. Second is that this should be a transparent methodology that is available to all stakeholders and to the public, and that it should be informed by methodologies used in other states. That there should be an annual review process for reviewing and revising the methodology as necessary. This task force talked about the need for some flexibility for this measurement process to potentially evolve over time. And here in the annual review process, we're specifically proposing that the recommendation include consultation with a primary care advisory body. On the next slide, we speak a little bit more about establishing an ongoing primary care advisory body to advise on primary care policy and rulemaking, including on providing technical input to CHIA's data specifications and measurement process. This was a concept that was discussed at the Data and Research Work Group about the need to have an ongoing entity that is being able to provide really that expert input into this process. And then the final 2 sub-recommendations here is that the legislature should direct CHIA and HPC to report annually on primary care spending across a number of different variables by member, by age, by insurance type, by age group, by payer, by managing physician organization, et cetera. And then finally, that we should use this measurement process for the purposes of setting a primary care spending target, which we'll discuss a little bit more today. Next slide. And then finally, as part of the proposed recommendation, we would include a section here that discusses some of the known limitations that the task force has discussed and direct CHIA and other state agencies to continue to explore and seek to address these issues to the extent feasible. And I won't read through all of these, but some of these were topics of conversation among this task force. The inclusion of original Medicare data, the consideration of other professionals that serve in a primary care setting, and for a way to potentially measure services that are not billed through insurance codes. So we include this list really as an area documenting those considerations that this task force had identified for further examination and exploration as CHIA would continue this work into the future. So that is the proposal that we would love to get your feedback here today as we continue to refine this and drive towards hopefully a final consideration at the September meeting. So I'll pause here. This was the kind of the outline that we wanted to present to you, and really happy to take comments and questions and input from all of the task force. Dr. Critchlow, please.
First off, really appreciate the organizational structure. You guys have been putting a lot of work into this. I will say that one of the concerns I have is a lot of these are recommendations that are currently in legislation. And I would like to know if our deadlines, these statutory deadlines, are going to allow us to provide a pathway if the legislature would like to use the bills that are in place to move these ahead. I would like to know if we have the ability for these reports to land in time for, honestly, some of the bills have exactly what we've put into these proposals. So please give some information on that, because I think that that would be very helpful.
Thank you, Doctor. And actually, the slide, if you just want to move to the next slide, I'll just quickly show that we did review some of the existing pieces of legislation that are before the legislature. And the three primary proposals all do defer to CHIA in terms of defining and measuring primary care spending. So this proposed recommendation is very well in line with some of the current legislative thinking. I think our recommendation, adds a little bit more specificity to that and some additional considerations. But I'll just say, and I'm going to turn it right over to Senator Friedman now, that this our recommendation is well aligned with current thinking. But Senator, I appreciate your thoughts and input.
Sure. Thank you, David. This is great to see kind of written down. Yes, Renee, to the extent possible, I will speak for the Senate in that we will do everything to align with what we're seeing in between the bill, the primary care bill, and what's coming out of this working group. And we'd have some time to do that. And those bills are currently been reported out, but we have some control over when, for instance, the Senate would take it up. So I think it's really important to keep. It's really important to keep looking at that. And we know also that it was a funky thing, right? Because we knew that we knew that we were going to be doing a bill, but we knew. But we also knew that this was happening at the same time. So we'll, in an effort to keep things moving, but to get it into some kind of statute, we'll pay a lot of attention to that. I have two things, just David, to what I've seen here. If you go back 2 slides, I would think it's really important that when we talk about the advisory board, that we are very specifically call out FQHCs, that they are a unique and identified entity that should be on the advisory board, because of all of the entities that we look at, they really are, many of them, at the forefront of what it means to deliver primary care in its entirety. So I would just recommend that be called out, like behavioral health systems, including federally qualified health plans, because we just want to make sure that they are at the table and that they are part of sharing their expertise in this space. And then the other one I think is on the next slide that I just didn't quite understand, which go
back, go forward 2 slides. One more. This one.
Okay. I guess it's the non-bill, I guess just how we talk about the non-code or right now billable pieces of primary care that are currently are what I would consider part of primary care. like the inclusion of OBGYN provider spending only for primary care services. Well, turns out that in some of the, again, the community health centers, they actually deliver babies, right? Now they may do it through a hospital, but they have a very wide range of what they are providing as part of their primary care. So I would, I guess it would be the inclusion of the things we don't know about or the things that we identify that would be spending only for primary care services. If I understand what that means, which I'm not totally sure I do.
So, thank you, Senator. I think on the first point, adding and specifically calling out FQHCs makes a ton of sense, and we'll make this change. I think on this specific bullet on the OBGYN provider spending, I think what we were trying to reflect there is what we know now is that we are including, or CHIA is currently including spending by OBGYNs and both for kind of wellness visits and in an attempt to be sure to try to include prenatal visits and other visits kind of before and after childbirth. They ran into just an issue that a lot of those are bundled all together, including kind of the labor and delivery expenditures with the kind of visits around that. And as a result, adding all of the kind of a lot of labor and delivery expenditures into the mix, things that are happening in hospitals, it kind of inflates a little bit what we might call primary care spending. It's a percentage point. This is it's not swinging wildly back and forth. But I think the idea with this particular bullet was to perhaps kind of nudge CHIA to think about, is there a way that they can still appropriately capture all of the kind of primary care visits and work that OBGYNs are doing, with maybe being able to somehow adjust out the expenditures that are kind of very specifically on the labor and delivery. So that is kind of the what the reflection of that particular bullet was.
Okay, thank you.
And I'll just add one more thing, Senator, which is, I think of this list as kind of a list of things to kind of keep thinking about and considering. And we may want to reflect on this list too when we go to our next conversation, which is, are there additional reporting or information that we need that goes beyond what we're currently collecting? Dr. Friedberg.
Yeah, thank you. I like the overall direction here being proposed. I think an annual review cycle makes sense for many reasons. Coding changes, for example, are going to have to be tracked and updated, and that's about the pace of coding change in general. I also like the idea of a primary care advisory committee or board, and hopefully, the kind of pros and cons that are discussed will be publicly released, because there isn't going to be one perfect way of doing this for exactly the kind of reasons we've just discussed around inclusion of OBGYN services. One thing I just wanted to offer is to make sure that if this is the intent, that it's not interpreted as an exhaustive list of the expertise that may be necessary that's listed there. I would add the original methods for calculating primary care spending didn't originate with any of the entities here that are listed currently on slide 11. It originated with a foundation and some academics. And I think those are the kinds of expertise that's important for kind of very niche technical topics, like the one that is going to be informing CHIA. I would also include legal advice and regulatory advice, just to make sure that we're always keeping an eye on federal mental health parity legislation, or regulations, I should say. Thanks.
Great comments. Thank you. Christina, how are you?
All right. Pardon my casualness. I'm on vacation this week on the Cape. I just wanted to pick up on Senator Friedman's comment, which is that for FQHCs, a lot of this data on what it costs to deliver the type of comprehensive primary care services that health centers deliver: physical, behavioral health, social, oral, and other supportive primary care services. It's not going to be captured in claims data. So it's more understanding what the cost data is, the cost of providing primary care. It's not something that would be measurable from looking at claims data.
Thank you, Christina. And I think that will that helpfully tease up, I think, our next conversation, which is going to talk about, again, are there additional things that we need to understand about both primary care spending, primary care costs, with all of this building towards we wanting to have a greater investment in primary care, and how do we track that? How do we make sure that's going into the right place? How do we make sure that that's ultimately having an impact? So that's kind of what we're building all of this towards. But I absolutely appreciate your comment. Other thoughts and considerations on this draft proposal for deliverable number 1? Dr. Mellon, please.
Yes, thank you. Very excellent and thorough work. I'm about to ask a question that I believe is probably ahead of where we are, but I'd appreciate your thoughts as to whether it's something to consider now or to wait until we get to future deliverables. And that is, in looking at the set of criteria that are proposed for this item, it seems to me we're looking at who did it, who provided the care, right? What care was provided, and that's by often determined by coding, although we've discussed some ways in which other costs could be factored in. And thirdly, a site of service, or where the care happened. So, for example, I'm a primary care physician, and when I'm providing care in our general internal medicine division of the sorts described here, then I meet all 3 criteria. But let's say I were also working, it don't happen to be, but let's say I were also working in our acute care center. It's called that. You can imagine what sorts of things happen there. I would be providing exactly the same care that I would in my office, right? And I'd be coding the same for the bad sore throat or the abdominal pain, whatever. But my here we'd be looking specifically at my site of service, right? So that in this instance, I'm across the street in our other building, right, and providing the same care. So I'm wondering what we know about experiences of other states or studies, or what the scientists could share with us about the impacts of each of those 3 items. And there's the example I used is a fairly straightforward one. There's another one that I'm very interested in, potential unintended consequences. And that is, let's say one of my subspecialty colleagues, perhaps a nephrologist and a kidney specialist, is seeing a mutual patient of ours. And he identifies, in speaking with the patient, that she seems to have a urinary tract infection. That's not core nephrology work. That's something a primary care physician would typically address. However, the nephrologist is also expert at that. And he addresses it during the visit, right? So now we've got a primary care service, but he delivered it. And so it's not going to go into the PCP bucket. I get that. Has it been seen that in instances like that, a patient is instructed to instead go across the street now and see your PCP, to get help for that UTI, urinary tract infection, that you seem to have right now. That I think we'd all agree is an unintended consequence, right? And so when I say perhaps we're getting, this question is ahead of where we need to be, I just wonder if we keep those potential consequences in mind. Thank you.
Thank you, Dr. Mellon. And let me take a shot at responding to that, and I'll ask Lauren Peters to correct me if I'm wrong. But on the first issue, the way that the CHIA methodology currently works is it's identifying primary care providers, and there's a list of different professionals that kind of fall into that category, and then primary care services. And for the most part, that is what is then considered primary care spending. So in the example of that primary care provider who may be providing primary care services in an acute hospital setting, that's still in the primary care bucket. There are some location variables, I think very specific to FQHCs, which kind of says like anything in an FQHC is primary care. But it's really more tied to the taxonomy of providers and services. I think to your second question, to me is more of a kind of a research a question that I would be interested in as well, and it's something I do think we can track and understand. And I think sort of the beauty of what the CHIA process is that it we can toggle on and off some of these different variables and get a different result. And how we use that result, I think, is we want to be thoughtful about. But one could, for example, just look at all primary care services and remove kind of the toggle of provided by a primary care provider and see what those are. Where is that happening in your example of perhaps a non-primary care provider providing a primary care service? And with the claims data, we do have an ability to kind of see the course of a patient's care, longitudinally, and could identify, does that patient have a primary care provider that then they have encounters with at a later date. So a long way of saying I think part of the strength of this foundation that she has sent is it allows for us to be able to look and answer some of those questions. And as we think about in the future where we want to put more money into primary care, what are the things that we're going to want to track to make sure that we think that money is going in the places that's going to have the most impact for patients and the most impacts for strengthening primary care. So I a rough shot at trying to respond to your thoughtful comments and questions.
Thank you so much.
Dr. Altman.
Thank you, David. So we have an incredibly ambitious task ahead of us on this task force to accomplish all the things that we need to accomplish. And we've had some really thoughtful discussions about this. We all agreed that perfect is the enemy of good. There is no perfect definition of primary care. It's impossible. We could spend weeks all together. We still couldn't come up with a perfect definition. And I think CHIA has done an incredibly thoughtful and good job at putting this together. And I think, David, you and your team have done an incredibly good job putting what you just presented to us together. And I would propose that we put a big green check mark by this agenda item for the primary care task force and say, hey, we did it. We have a mechanism here. We have it. And let's say goodbye to this agenda item and move on to the next bits of work that we have to do. I think the structure of having CHIA do this work, having an advisory board and annual reviews, it sets the whole thing up perfectly, I think, for good definitions of primary care ad infinitum.
Thank you, Dr. Altman, and I appreciate your support. And that is, exactly what we're trying to propose to do here is keep moving through these deliverables. They're going to get harder, right? But let's stick to it. Barbara Spivak and then David, and then I might move us along to the next agenda. But go ahead, Barbara.
Thank you, and thank you for the work. I agree with some of our previous speakers, and I think what's clear is that one of the reasons our specialists today are doing more primary care is because there is not enough primary care access. And what we're also finding, which is not part of the agenda, is that there are certain specialties where we don't have enough access. So primary care doctors are doing more specialty work. So I think improving the whole system will really help improve the quality of care that we deliver. I think this is the right approach. I think that having a primary care advisory task force is going to be important as we move through very difficult issues. I think that when we look at primary care, one of the things we might think about is trying to see the differences based on, if not age. I don't think we need to do it age, sex, but certainly by age, because the needs of our pediatric patients in primary care are going to be somewhat different than the needs of our geriatric population. And as we look at how we measure spending, particularly around what is not reimbursable, we may want to add that into our thoughts about how we can do that. Thank you.
Thank you, Barbara. And I'll just add one note on the last comment she made, which was, we looked at kind of the proportion of spend for different age groups on primary care, and we found that overall the growth is very slow compared to spending on all other medical services. But when we isolate in on the pediatric patient population, the growth in primary care spending is almost flat. So there is even a difference kind of depending on what age group you look at. And so I think that granularity will allow us to identify, again, like if we're putting more money into this system, where is it going, to what patients, and do we want to be targeted in some way about that? David.
Great, thank you. So I'm not going to reiterate what the prior two speakers said. I agree with all of that. My only comment was going to be that maybe this is a detail element of seek to address in the future. This part of the work is foundational to the other parts of the work. And so I don't know if the recommendation has a specific timeline that we want to put into it. Some of these elements, I imagine, don't need to be legislatively accomplished. And so if we put a specific timeline in that recommendation, in order for us to continue to do the work we need to do, I might strongly advise that.
That's a great point and a great thought. And I think the fact that Chia is doing this work, we can kind of piggyback off of that, but I like that idea. And as you said, this really, as you'll see through this conversation, this is the first building block of where we're leading towards. So I think with all of that great input and feedback, we'll propose to make a couple of tweaks to the proposal that we've discussed today based on some of the comments here, maybe specifically around the primary care advisory group. And that primary care advisory group may be something that we continue to want to talk about what their role may be on some of these other deliverables as well. And what I would propose is we will circulate as co-chairs kind of a final draft to all of you. And then we can put the big green check mark next to this first deliverable. Seeing some head nods, I appreciate it. And thank you. Thank you very much. So with that, let's move on and start to talk a little bit about deliverable number 2, which is around identifying if there is a need for additional data and reporting requirements of payers, providers, and health systems. So we began this conversation at the Data and Research Work Group, but wanted to bring it to this full task force for all of your input. We don't have a proposal here today for you on this one, but hope that your input will help us guide a proposal that we would bring back at the next meeting. So as we just discussed, Chia does collect expenditure data based on, primary care spending from billing codes, aggregated up by the health plans, and reported as primary care spending. In addition, Chia does collect information from the health plans about non-claims payments. So payments that do go to providers to support a range of services that aren't necessarily put through the same type of billing codes. What we have heard from the health plans, however, is that they often do not have insight into necessarily how those non-claims payments are distributed within a provider organization. And so as a result, are often uncertain about how to report to the state how much of those non-claims payments are going to support primary care. And as a result, this may be a gap in our current understanding and thinking of primary care spending. And again, to the extent that we want to, in the next deliverable, talk about increasing the expenditures in primary care, one way to do that is going to be through non-claims support. But do we understand that if we increase non-claims support to providers, is that going to primary care? And so we talked at the data research work group about this issue of understanding what we kind of commonly call funds flow, or the method for distributing, non-claims revenue or settlements internal to the organization. We also had a conversation that was more broad about the fact that many primary care physicians and practices are part of larger health systems, and that these larger health systems have internal accounting mechanisms that may allocate certain types of services and supports to primary care practices that, again, is not transparent to the state or to certainly maybe to health plans. And so we, on the next slide, kind of came to a synthesis. We can move forward one more slide. Of two areas of further conversation that I wanted to bring to this group today about, is there a need for additional reporting in these areas? Is it feasible to be able to collect this information? And would love your input. So the first bucket here is reflecting that members have called for transparency of the specific formulas used by provider organizations to allocate those non-claims payments to PCPs, as well as the amount and distribution of those dollars. The second big bucket that we talked about was understanding the financing of primary care practices within larger health systems. Members reflected that it may be important to track, are there clawbacks or things that are being charged back to the primary care practice within these systems, or other types of administrative or support services that are being provided by an MSO or an ACO structure, and that, again, there is little transparency into how within these larger systems primary care practices are being supported and revenue is being directed to them to support primary care. So I'm going to leave this slide up here and ask perhaps even members of first the data and research work group, does this kind of reflect the two buckets that we talked about in terms of the areas where we might need more information, and really want to open it up to the full task force of, are these the right two buckets? Are there other buckets? And then maybe talk a little bit about how we might do this. So Dr. Friedberg.
Yeah, thank you. I agree. These are two of the things that we discussed, and I guess I had thought we maybe had a more general discussion. So, and I'll say in two specific ways. One was this is of course a problem for non-claims payments, but it's also a problem for claims payments. We have no idea how those are tracked internal to an organization either. I don't think we should be only looking at non-claims payments here. The second observation is funds flow formulas. I think maybe just needs a definition. I worry that's going to be interpreted as like an equation that someone can write down. And there are instances of that where, for example, there's like a tax applied by a large provider organization on all fee-for-service claims received. Like they take 10% right off the top to fund some kind of population health management program or something else. And I think those are kind of rare in my experience, that there's something written down like that. So we want to say like fund flow or other mechanisms or something like that. And because it seemed a little bit too narrow, and it's easy enough to have something that isn't in a formula, but is still diverting money intended for primary care away from primary care.
Yeah, really, really helpful feedback. And I think, really this was put up here to get your reaction and others' reactions. And I think that the problem of the complexity and variation about how provider organizations do this is something where we may have to resolve ourselves to have a more flexible approach to how we define some of these things and allow for the agency ultimately responsible for collecting this information to have the kind of the flexibility to work with different organizations and to be able to have definitions that would be applicable in different ways. So I appreciate that. Commissioner.
Thanks, Director Seltz, and thank you to the team for another great meeting and a lot of work leading into it. I would just comment on the real need to widen the lens towards claims and non-claims payment, echoing Dr. Friedberg's comment. And in fact, I think the vast majority of dollars that we're going to be concerned about is in the claims category and is not able to be tracked sufficiently to the level that we want to be able to do so. And while we don't have to, I think, nail this down completely, I do think there's something to the ability of the data agency to request additional information that may help educates them directly from provider and provider organizations. I think the concern that I have is that the insurance claim information or the insurance sector will give you a warped and incorrect view of the funds flow. And therefore, there's a direct to provider request or information share that we have to build out. So, but I'm intellectually consistent with where you're going on this slide. So thank you.
Commissioner, can I ask a follow-up question, which is one of our questions that we've been thinking about? I think you just said it, but I'll ask it more directly. Is this information that should be reported to the payers and then from the payers to the state? Or do you think that this is information that should be shared both with the payers and with the state directly from provider organizations?
Yeah, it's a great question. I think I'd be really reticent to have the payers be the funnel of the information down back into the state. They can be a check on the information, and frankly, it could be a verifying data point, but the provider organizations should be asked for the information directly, and they should want to give it, frankly, because it's the only way to get verifiable information directly from the source. Now, that will require the build out of data sets and all of the work that CHIA, for example, does so well over time with their provider partners. But I think in my opinion, I think it's a direct from provider request with maybe a verification check to the extent that the payers can give you that, as opposed to asking them to collect it. That's separate and apart from some other tools that we may want to think about architecting for the system on this particular topic. Because if you're holding carriers responsible for the funds flow directly down to the provider group, primary care provider group level, I think you'd also have to think about statutory tools that would allow them to have greater scope into that world that they do not have access to now. In many cases, they're directly contracting with the larger system. They're not contracting with the provider group, and that's the nub of the issue that we're trying to solve for.
Yeah, thank you. And I will pre-ask Ryan, your fourth up, Ryan, but I know Mass Health has thought about that exact issue, which is like, are there contractual ways that payers can try to have greater clarity and understanding about the funds going directly to the primary care practice and to the TIN? But I'll hold on you, Ryan, and Renee, please.
Number one, do you support what the commissioner was talking about? Twofold. As an FQHC CMO, I want to be really clear. If this adds more complexity, I don't want it. That's clear. If this is going to make me have to hire another person that is not doing clinical care, I don't want it. So part of what I am asking for is, if we are looking for a real long-term change, don't let don't let perfect be the enemy of the good. Let's get something from the claims that is easily dealt with and doesn't add more bureaucracy or challenges around my billing. The other part is, I will be really clear that if we create the ability for folks to, in a simplified manner, do primary care in private practice and not have to work for these healthcare systems, if we do that, the healthcare systems will definitely be pushing more money towards primary care, because people will leave them if they do not. So that is the way that we can do this without adding another layer of complexity. Make them afraid that they're going to lose all their primary care providers, and give primary care an opportunity to thrive in an ecosystem where it cannot thrive right now because of the complexity of care delivery. And not so much care delivery, the complexity of billing delivery. If you remove the billing cost and allow us to do clinical care, more of that money will go towards clinical care. More people will be able to be in private practice or in FQHCs providing care. Because the fact is, if the big systems have to demonstrate that they're putting money towards primary care, they'll show you how they're doing it. If you ask them, they'll show you how they're doing it, because they have to show their primary care providers that they're putting the money back in. So if we build this right, the system should self-correct, because the health systems need to be able to demonstrate they're putting. I don't want to tell the president of UMass how to use his money. I want him to be smart enough to know that if he doesn't put the primary care money back into primary care, he's going to lose all his primary care providers, because they can go out and start their own practice. That's how we keep them on the right path. That's how we keep money flowing toward primary care. We make it easier to do primary care.
Thank you. And I appreciate, and Senator Friedman said this as well at our work group meeting, that whenever there's a conversation around perhaps the need for additional data reporting, I think we have to be mindful of our charge here as well, and understanding that administrative burden and is part of what got us into this mess. And so I really appreciate your perspective on that. Thank you. Dr. Pring.
Thank you. I just wanted to, comment that I think it's excellent to sort of want to track this information. I'm supporting the concept of transparency and really seeing what is getting down, honestly, to the provider level, the PCPs themselves, not just to the practice, because again, that falls into potentially a black hole for management, or paying, for staff to help do some of these initiatives, but trying to figure out what gets right to the PCP. Obviously knowing that some of these staff members may help manage, a panel of diabetics and things, tracking A1Cs or whatever these sort of metrics are, and these quality measures that the ACOs are potentially giving. And in an effort of potentially unintended consequences, or maybe for another part of the meeting, I'm just curious if there will be, or another part of our agenda down the line, burden of potentially, delegating a certain percentage of that spend, that millions of dollars that are given to the ACOs at the end of the year for meeting certain metrics, if there's a requirement that what percentage of that goes actually to their care providers that are actually delivering the primary care. Just some thoughts.
Thank you. And I think on your last point, I think part of our conversation will continue today is around this concept of setting targets for increased expenditures in primary care. And typically those have been done more on kind of an aggregate and global basis, kind of by payer. And I think what the concept here, though, is that, if payers are spending more on primary care, whether that's through claims or through non-claims, again, how do we see that is actually going to the place where we want it to go? So mandating a certain proportion of those may not be necessary, but we may want to think about, is there enforcement or some type of requirement at a system level to say you should be spending X amount on primary care, and how you get there, you might have some flexibility. Christina Severin.
Yeah. Thanks. A couple of things. On the top of the page, this is another example where MassHealth has done a really, really good job at coming up with primary care capitation that's paid prospectively, with an understanding of what goods and services are included in that, and specific contractual obligations around what percent of that primary care capitation has to directly go to primary care providers. Speaking as one organization that receives this primary care capitation, we do not even book it as revenue. We just catch it from state government and immediately push it out to primary care providers. On the second half of the slide, I think it's reasonable for provider organizations to have accountability. I think that health plans should also have accountability, that it should be bilateral. So, for example, that health plans are responsible for meeting certain targets of whatever they are paying to the contracting entity. In the example of a health system, that a certain percent in that contract negotiation, that primary care is a specific piece of the contract negotiation, and the total economics of the contract need to be equal to X percent, whatever the target is developed for primary care spending. That could also be true for non-direct care, and you're calling them claims payments, but non-direct care support payments that health plans could require, and health systems would need to be accountable for a certain percent or all of certain non-claims payments that are being paid for population health management to go to the primary care practices, or somehow be linked to the provision of comprehensive primary care and care management and population health.
Thank you, Christina. And I think you brought up an important other reflection that I've had in thinking about this problem. This problem of knowing, if we put more money in the system, how do we know where it's going? And I think you raise another mechanism that we should have on the table too, which is, are there payment methodologies and contractual agreements that more clearly provide that capitated payment to the primary care practices, like what MassHealth is doing by having that subcapitation program? Is that a way that we may be less worried if we have those payment methodologies, not just for MassHealth, but for other commercial plans as well, in thinking about this concern about how do we know where the money's going? And so I think I've teed you up perfectly, Ryan, for your thoughts and considerations on this topic.
Thanks, David, and thanks to everybody for your comments today. A few thoughts going back a couple. One, as Christina just mentioned, MassHealth, for those familiar, does have a program where we capitate primary care, and through our contractual mechanisms with 17 ACOs throughout the state, we do require that health plans report back to us the actual percentage of those dollars that go to practices at the TIN level, as a part of our payer contract with our health plans and with our ACOs. While Christina, I'm delighted to hear that you guys don't book this as revenue. the flip side to that is I don't think that we as a Commonwealth should be naive to assume that all systems think of these dollars in that way. And we don't have visibility to the level that we would, I think, ideally like to really truly understand, like, as a primary care practice, like what in my practice, like what dollar, what cents is actually getting there out of the Mass Health dollar. We do not necessarily have that visibility across systems. And I think the second bucket here at the bottom of the slide is really important for us to better understand and hold both payers as well as provider systems accountable if we are going to ultimately increase investment in primary care. And David, we're getting to the spending target. If we set a spending target as a Commonwealth, we should also be confident that on the payer side, that those dollars are actually being used for primary care. And from the individual practitioner, the primary care provider at the practice, I think we would all like them to feel confident that if the Commonwealth says they're going to spend X percentage on primary care, that they as a provider can actually expect those dollars to be in their practice invested in a way that they can actually take care of patients every day in a more meaningful way. I don't think we yet have that visibility. We have learned a lot working with Lauren's team at CHIA over the last couple of years to try and operationalize some of these structures. I think we have a lot more work to do as a Commonwealth, and hopefully multiple payers and many provider systems around the table thinking together about what is the actual data set that we do need to report, and how will that actually give us confidence and visibility into the actual dollar making it to the primary care provider. Last thing I'll say is, Renee, I completely agree, and the balance here is about administrative burden. There is a very real trade-off, and we have certainly learned that in some very practical ways over the last couple of years in thinking about billing codes. For example, FQHCs. For those of you familiar, most of the codes that Renee and her team bill are T1015 codes. Well, the T1015 code actually doesn't offer a tremendous amount of specificity or granularity as to who's billing that or what the service is. And so there is ultimately a trade-off in terms of how you think about the data that we have as available as a payer and ACOs have available as a payer and where that dollar is going. And so I think, just to reiterate Renee's point, we also need to be cognizant of that trade-off, and we would probably shoot ourselves all in the foot if we ended up creating more administrative burden at the individual primary care provider level in the spirit of trying to have more visibility. So not sure we're ever going to get to the perfect, but I think we do have more work to do, and hopefully with other payers around the table and provider systems.
Thank you, Ryan. And you raised a number of really important points there. And I think just on the last one, if there are some need for additional reporting, at what level is that happening? Is that happening, kind of at the system level and not necessarily at the practice level? I think, another reflection just that I would share based on your comments is that there's no one right way to do this, that there is, I think, have experienced, Mass Health has experienced that it's taken some time to kind of think through some of these issues, to think about the variability of different provider organizations and how they're internally structured to do this work. I will share that all of the other states that have primary care spending targets are wrestling with this issue too. We are not alone in identifying that this is a dynamic that we need to understand. And so, I may suggest, as we think about driving towards a deliverable, that we're setting up a process for continuing this work and designating an agency to do that, but understanding that it's not going to happen overnight, and that there is going to need to be some learning, continued learning happening kind of from all of the major stakeholders in this. All right, I'm gonna keep moving. Barbara, please.
Thank you. I think as I listen to the conversation, I think that we need to highlight that we're talking about two different kinds of services that we want to improve for primary care providers. We certainly don't want to do anything that's going to increase the administrative burden to what clinicians are doing. And in fact, we want our systems and offices to be able to pay for people and AI to take away the burdens so that I, as a primary care doctor, can spend more time with patients rather than on doing billing codes, diagnosis codes, prior authorizations, filling out ridiculous forms, etc. But there is a much equally, or if not more important, what we want to be able to track is what is the practice able to do to help patients? Because when we're doing primary care, we identify many gaps for our patients. Food insecurity is going to increase over the next couple of years. Do people have housing? Do people live alone, no family, on the third floor? And when their drugs are delivered by CVS, are they left in the, outside the first floor door and they can't safely get it? We need social service care managers, pharmacists to really help us deliver better care. So what we really want to do is also look at what other services is the network providing or the office able to provide that are helping patients get the care that they need in the right time at the right place. And it's not just about administrative burden and decreasing that so I can do better care and have more time. It's really both. It's doing that and measuring that. But maybe even more important is measuring what is available to me in my office so that when I identify that a patient can't get out of the house and I need blood tests on them, that I can get someone to go to the house and draw blood and not have to have them spend $200 to do it, but that somehow there's a free group that will do it and get me the result I need. It's many things like that of support that impact the patients that we also need to track. Thank you.
Thank you. And I think you articulated and highlighted that we're going to have to try to tackle all of these things. Like there's not one solution to this issue. It is going to, we're going to be talking in the workforce work group about reducing that administrative burden. But we should also be talking about what do care teams look like? How do we support that? How do we have the right group of individuals that can think about the medical, social, behavioral needs of the patients? And so I appreciate the comment, and I think it just adds to a need to try to make progress on a number of different fronts to have meaningful impact. Lauren, I'm just going to skip over you for 1 second and ask the senator to please weigh in. I know these are issues you've thought a lot about.
Yeah, but Lawrence has as important things to say as I do. But yes, okay. Yes, we have thought about this quite a bit. One thing, I think to Barbara's comments, that's part of what we have to do to define primary care. That should be within the definitions of primary care. And to follow up on Renee, I started to think about looking at this slide. What I'm struggling with is we're trying to track data in a system that doesn't work. And it seems to me that maybe it's really time for us to just flip it and say, okay, what should the mechanism for paying and delivering primary care be? So, and then track that, because I just have no faith that we're going to be able to come up with the right set of data, that we're going to get the information we need from these systems, which have a real vested interest in doing something different. It's not a bad thing. I'm not judging them, but I'm just saying their job in life is to fill beds. And the whole primary care space for them is probably, other than it's a phenomenally good feeder to their systems, has been is probably somewhat of a burden. And so I really bet we need to shift this. And one of the things that's come up a lot and that, I'm a big fan of is this whole, can we structure primary care in a way that makes sense to the providers and the patients? And then can we require that in some way to be delivered? So Medicare, Medicaid, Mass Health has a subcapitated system. It's not perfect, but it's absolutely headed in the right direction. So what happens if we say, how do we move that kind of model to the commercial space? And how do we do that so we relieve the administrative burden, make sure that that the definitions of primary care are adequate, right? And then what do we do to require, to ensure that providers are going to want to go to that, to make it easy for them to do business in that way? But I think I'm just fundamentally looking at this and saying, we continue to ask for information and ask for information. And I think it's kind of time to say, we're never going to figure out how BI Deaconess or the BI system internally creates all their contracts to deliver money to primary care and what they claw back. So I just feel like I think maybe we need to just start flipping this and talking about not the information we need, but what it ought to look like in much more detail. And I think using Medicaid, the Mass Health, is a really good place to start. So that's kind of what I'm feeling. While I'm listening to everybody, this is a really, really good conversation. But that's kind of where my mind's going.
Thank you, Senator. And I agree. I think that there is value in thinking about what is the payment methodology that we want to support, and can that be the mechanism that gives us the assurance that the money's going into the right place, rather than trying to track every single dollar. It is, as we have been discussing, so variable and complex. And I do think that the Mass Health program, I think, is a real opportunity. I mean, that is a program that also has different tiers of payment for the capabilities of those practices and what they can do and what the care teams look like. And so there's a lot to gather from that. And I'm happy to talk to Kiame about maybe pushing that part of the conversation here forward. And even as we're, thinking through this piece, but maybe that conversation should be advanced. Thank you, Senator. Lauren, how are you?
Great. Good. How are you? Thank you for just recapping the data work group. I think it really does capture the two dimensions that we were focusing on, both the non-claims, but also the provider system accounting, which in many ways I see as the bulk of investments and payments into the primary care system through claims. I would echo sort of agreement and appreciation for the senator's comments about the reframe, and not necessarily just continuing to collect data and information on the existing system that we all know is broken. But I think as we think about what information could be helpful to collect from providers, we should not be necessarily thinking about providers as sort of all one and the same. We may not necessarily need to collect the same level of information from FQHCs or other community health centers as we may want to from the larger systems. And I would just throw out that CHIA currently collects data from cost report and financial data from the large systems. And I do think that there is an opportunity and an importance there, because right now the way that we're collecting spending data from providers is through attributed patient spending from that given provider organization. So it is a fairly crude metric. And as we think about setting targets, I do strongly believe that we need to be holding both payers and providers accountable And I do think we will need a probably more tailored, stronger metric for measuring provider spending and investment in primary care than the one that we currently have today.
Thank you, Lauren. And as you mentioned, we do have existing platforms like the registration of provider organizations, which are more isolated to the larger systems. And through that program, we have collected at least qualitative information about their fund flow mechanisms as an example. And maybe a platform we want to consider leveraging for, as you framed, more of an accountability that if we're setting spending targets, how are we holding the health plans and provider organizations track their progress and hold them accountable if need be. Suzanne.
Thanks, David. And thank you, Senator and Lauren, because I wanted to echo your points as well. I was thinking about just how different practices or different systems or FQHCs versus systems might need different levels of information, and echoing the Senator's comments about kind of flipping the script a little bit. The only thing I wanted to add in this, David, you were starting to get to this and other people were, is, and this maybe something that's obvious, but just thinking about that there is data that we're like HBC, CHIA, Mass Health are already collecting, and are there other kind of best practices and other contractual agreements, for instance, that we might not even know about, that where data is being collected, and how can we use best practices within those and then identify those areas where we feel like we do need that more information, and what are the barriers to getting that information? Are there legal barriers, legislative barriers, regulatory barriers that we can identify if we do feel like we need more information to track something? And again, that balance between administrative burden and having the information that we need, I think, is really important. But as we're moving towards setting the spending target and changing the way primary care is paid, it may still be that we do identify gaps of what information we need to actually hold systems accountable and carriers accountable for making sure that that investment goes to where it needs to be. So I feel like it's like we can kind of utilize some of the information we have already, but if there are gaps, what do we need to enable to get that? Is my main point. And then the other one, and this may be going a little too far, but I've just been thinking about, as we're thinking about where primary care spending goes, and this may be another recommendation of just thinking about whether of different populations that are served through different primary care practices, and whether there are existing inequities, whether on a variety of factors that we may want to just be attentive to as we're thinking about setting the spending target and any sort of alternative payment methodology. So just wanted to put that out there. I know that's later on, but thank you.
No, well said and very relevant to the conversation. Mark, please.
Yeah, thank you. I think the point raised about administrative burden here is really well made and should be absolutely a consideration here. I worry that, and of course, if the administrative burden of providing organizational accounting falls on clinicians or chief medical officers or anything like that, I think it's clearly not going in the right direction. This should really fall on the CFO and that part of the organization, to the extent that there is an administrative burden for providing some accounting and dollar flow. I want to really call out the importance of that sentence about what organizations charge internally. That's a blind spot, as I understand it, in pretty much everybody who's tried this so far, and that is everything. If we create a system where we are guaranteeing a certain spend on primary care, but guess what? There's inflation within an organization, and now it costs an exactly equal amount of increase for that EHR and other supports that the large organization provides to its primary care clinicians. We've achieved nothing. And that's my concern. We have to have some kind of way of detecting that. That's kind of the litmus test for me. And one way of doing that is to have a detailed accounting system that tracks those internal charges. Another way is to go straight to the to the end recipient of those funds, and you could ask the clinicians themselves, the leaders of primary care practices, hey, we put into a requirement that your pay had to go up by some percentage this year, and everyone, from the payer side was compliant with that. Did you see any evidence at your practice of that increase, and how much did you see? That could really kind of go around the need for an internal accounting system. And just a similar point on this, and I regret not saying this earlier on the part about what CHIA should address on setting a definition for primary care spending. This is kind of parallel to the internal charges within a provider organization. It has to address Medicaid provider taxes. That can really distort a measurement of primary care spending for Mass Health in particular. That's a critical thing to include there.
Yeah, thank you, Mark. I think you hit on something that I've been thinking about as well, which is, again, kind of following the conceptual logic. We as a state tell health plans pay more to primary care, and you do that through contracts. And do the provider organizations just say, okay, well, that just offsets the cost that we were already providing for EHR and billing support and other things, and the net increase in terms of support to the practices is negligible. So I think we're all circling around this issue. Ryan, I do want to spend some time continuing the conversation on the spending targets today. So I'm going to try to move us on here at 11:30. But Ryan, please provide the solution and we can move on.
No, I was just actually going to emphasize what Mark said and just offer a couple of anonymous examples. So in our program, we've spoken to many medical directors across the Commonwealth who actually have seen an increase in investment at their practice level, which has been great. And we've spoken to many medical directors who have said one of the following two things. One, I've asked my CFO where these dollars are and no one's responded. Or two, I've asked my CFO where these dollars are and they come up with some variation on a theme of the EHR example that Mark has shared. And I think another downstream question for us, maybe at some point, or whichever advisory body ultimately is enshrined, is what are valid uses of primary care dollars? And some of the things that we have heard invoked as to where primary care dollars are going, I don't know that this body would necessarily agree are the types of investments in actual patient care that we would like to see primary care dollars going to, as opposed to increasing subsidization of the EHR expenses or other system level costs that systems very reasonably do need to provide to practices, but where those dollars are, for lack of a better word, adjudicated or explicitly ascribed, I think is outside of the purview of today's discussion for sure, but it does raise the prospect that I think many of our primary care providers would not necessarily say that's where they'd like to see the dollars ascribed.
Thank you, Ryan. Dr. Altman.
All right. I just want to make a few brief points, and I'll try and wrap up soon. David, you said 11:30. Did you say AM or PM? No, just kidding. So I really am very confident that we are going to have historic landmark primary care legislation this cycle. And to that point, I think the ultimate purpose of this task force is to make recommendations that inform that process, to see to it that that legislation is as good as it possibly can be. And so when focusing on that legislation, we don't have to be in the weeds and solve every problem today. I think Senator Friedman's point was really key. And it goes back to Christina Severin's conversation about a prospective monthly payment. And when we talk about a prospective monthly payment for primary care, all of a sudden, this effort around transparency, the level of difficulty comes dramatically down when we're trying to achieve transparency. I've been talking to Senator Friedman about this issue for a long time, and she has been obsessed with transparency. I use the word obsessed in the best possible way. And I am so appreciative of her and her team for really demanding that there's transparency. And I think that having the structure that we're trying to create here in these slides that you laid out, and with a primary care advisory body, we can make recommendations for legislation and then trust that the advisory body can see to it that there's not undue administrative burden, that we structure it the right way. We really can't get in the weeds with legislation. And the last thing I'll say about this incredibly excellent discussion that we've just had over the last 20-30 minutes really is done a beautiful job describing our Primary Care for You, PC for You legislation that we've been working on for 6 years. You all have done a great job. All the points you've made are exactly what we've come to with our PC for You legislation. So thanks everybody for this great discussion.
Thank you, Dr. Altman. I'm going to move us on to our final agenda item because I do want to make sure that we're continuing to kind of build towards, a cohesive package of recommendations here. I will. I think we want to reflect a little bit on this conversation. I think Dr. Altman, ultimately thinking about a deliverable on this piece that sets up a process with some principles and some structure, but I don't think that we're going to be able to solve all of those technical details in this particular group. And as we discussed on deliverable number 1, this idea of having a standing primary care advisory group that it will exist beyond this task force to help inform and guide some of that technical work and some of that in the weeds work, I think can be a core part of how legislation ultimately could tackle some of these issues. So thank you all for a great conversation on this and more to come. In our last half an hour together, I did want to return and have a little bit more time and space for a conversation and discussion with all of you, reflecting on the presentation that we had at the last meeting with Chris Kohler from the Milbank Memorial Fund. And I thought he gave a really spectacular presentation, and we had a lot of opportunities to ask questions of him and how other states are doing this. But I really want to start hearing from you all about what your thoughts and principles are as we think about a primary care spending target. I've included this slide that's really directly kind of taken from his slides, which are around what he had said. Here are some of the design questions that you should really think about when doing a primary care. He called it a rate, I think a rate target, spending target, investment target. There's different ways that these are called in different states. In this particular legislation for this task force, it's called the spending target. But really the concept is to increase the proportion of healthcare spending that is going to primary care and setting a percentage target. So the first couple of questions here are the ones that I was hoping to spend a little bit more time hearing from you all today. One, should the spending target be aspirational or a requirement? Should this be something that the state kind of sets and hopes that the healthcare system ultimately achieves, or should there be some mechanism for requiring an accountability? The second is, what should the spending target level be? Is this something that should be put in place as an absolute percentage by X number of years, or should this be a percentage growth on an annual basis? There's different ways that states have tackled this problem. If we do think that there should be accountability, who are the accountable entities? And then ultimately, who enforces that accountability? So those are the questions that I wanted to focus today's conversation on. And Barbara, just give me one more minute, and I want to just share on the next slide. This is what Chris Kohler's recommendations were, and I put this here not to say that these are my recommendations or necessarily the recommendations of this task force, but just to remind you all what he suggested to us, that one, the spending target should be required, use CHIA, focus on getting better over time, that both health plans and health systems should be accountable, and to build off of current structures that are in place to ensure systemic impact. So I have some more slides that we can get to in terms of, if you'll allow me, Barbara, just to kind of finish the thought. So let's talk about what's the legislature has been considering on this topic. So there are a number of bills that we've discussed that are currently before the legislature that all include an idea of setting an aggregate primary care expenditure target. So this is a common mechanism across all of these bills. And in many cases, it is a target that is monitored by HPC and CHIA. Where they differ, if you move to the next slide, just move one more slide. Where they differ is in kind of the where they set the target over how many years, and is there a process for kind of modification in the future? So you can see the three bills here. All of them, though, generally, you can see here, are targeting 12 to 15% as kind of the target to work towards. There are a number of kind of design questions and principles underneath each of these. And so if I can just ask my team, maybe let's return to the discussion questions at the beginning. And would, love to kind of open this up. We're not going to land this today. This is really, continuing the conversation. And then to help us as co-chairs come back to you next time with, what would a straw man proposal look like? So what are your priorities, and how do you all think we should approach this idea of setting a spending target? Commissioner, I'm gonna go directly to Dr. Martin since he hasn't spoken yet today, and I'll come back.
Oh gosh, thanks very much. I'll be quick. Actually, more observation or question, but someone heading in a clinic right after this meeting, I couldn't be more grateful to have more funding and resources to do the work that our patients need done. From the start, though, I think question 7 has to be our guiding question. The money is a means to an end. And the end is really great primary care for people who are sick and suffering and need help. And having looked at states that have used targets with near term and its pioneers, they are still having very high levels of difficulty with access, including our Ocean State neighbor with people waiting up to a year or more for a new primary care clinician. So I just want to be, I guess, put something in the ground here to say the target and spending increase is necessary, but not sufficient.
Mm-hmm.
And that we to please have us keep that top of mind. That thank you.
Oh, thank you, Dr. Martin. And I agree. I think that this question is interconnected to other questions, which is, if we're increasing the investment, do we want to target that in some way to the types of activities and supports that are going to have the biggest impact? And how are we ultimately thinking about what does that vision look like, and how can we leverage those investments to get to that place and make sure that that is working? Because ultimately, I think another dimension that we'll have to wrestle with here is that there's a lot of money in the healthcare system already, and it's also we have affordability challenges with our healthcare system as it stands today, and so the idea of increasing spending, where are we ensuring that there's value that's coming out of that, and does that need to be offset? Commissioner.
The doctor went exactly where I was going to go, which is, I think the patient experience, the member experience has to be the driving focus and not just a dollar value. That's not to say that we should not have a spending target. I think it should be, in fact, a requirement. But it all should also track and create metrics around patient experience, the ability to see doctors, to be able to see an actual primary care doctor as opposed to another member of the care team over time, if we do this correctly. Patient wait times, provider directory issues, all of those issues have to, I think, be subsumed within the larger scale. That's not what you're asking, I think, specifically here. And so I'll just observe that I think the spending targets are important. I think they should be required as a matter of law and or regulation. I think there's some natural state agency bodies that make sense to play that role, meaning CHIA in the HPC, because the way that you conceptualize it is correct. There's a numerator and a denominator, and the denominator is information you're already collecting and reporting on, which is total healthcare spending overall. In terms of the accountable entities, it has to be payer and provide health systems both. Anything else would be laughable. You could not enforce this target, whether it's aspirational or required, against carriers only, given the dollar flow issues that we previously talked about. But I tend to think it should be a requirement. The spending target level is a harder question. And frankly, I'm not sure we know enough yet to land what the target should be. And I think we should be dedicated in exploring that issue or finding out more about what reasonable spending level targets should be over time. Not be afraid to tackle hard things, but to educate ourselves more about the target levels that make sense so that we continue to move forward and upward.
Thank you, Mike. And I'll just take one quick moment to just share with this group why I do think a spending target is valuable and needed. We have seen in the data again and again that the percentage of money going to primary care is going down. And I don't think this market has the tools to change that trajectory on its own. And it will continue to go in that direction. And when we see, in my observation, a failure of the market to be able to put the money that's providing that value, then there is a role for government, and a role for government to say, we're going to set a trajectory and a different course. We're all going to work together to be able to achieve that. But that is a mechanism that has been used before. We use it with a healthcare cost growth benchmark to set a target and a goal that we aspire to, and that we can motivate collective action to work towards together. And I think there is political and policy value in having that aspirational goal and being able to track towards it. That doesn't take away anything from the conversations about how are we actually going to then deliver better primary care, better patient experience, reduce the administrative burden, fix the working conditions in primary care. All of these pieces fit together. But we have to change this trajectory, or else the graphs that I'm going to show year after year is just going to show a declining percentage of medical spend on primary care. Thank you for that. Barbara, please.
Thank you. I think that we need to have a requirement on the spending target. that happens year after year with a long-term aspirational goal that would be dependent on what we are asking primary care to be. So we have to look at, is the spending target including the help that is to reduce administrative burden? Is it including the team that will include care management, pharmacists, etc., nurses, home care? I think before we can decide on a target level, we have to understand what is to be included in that target. And I think that, I've said this in a previous meeting, I think that people have hinted at it, but I think one of the ways to enforce accountability is to very simply say that primary care negotiations have to be done separately from the system, so that health plans are required to negotiate a primary care contract, either with an independent group of primary care doctors, an IPA, an ACO, a healthcare system, an academic system, whatever the entity is. Primary care is taken out of the specialist bundles, taken out of the inpatient, and it is in and of itself the entity. And we negotiate contracts with expectations of spending and what we want to be included in that. And that becomes much more easily manageable and accountable because it's all done in a very separate way. There would be an added and understandable increase in expense to set that up separately. But I think at the long run, the accountability would be so much more clear. And the goals, because as I've said before, you can't have a system in Massachusetts. All of the systems are either for-profit or academic medical centers whose goals are very different than what the goals of primary care are. So if we separate them, things become, I think, much clearer. Thank you.
Thank you, Barbara. And I maybe not today, but I'd love to hear from provider health systems and payers what they think of this idea. I'm going to use just my co-chair prerogative to just ask to call on some of the people who haven't spoken yet today. So Laura Black, and then Laura Pellegrini, and then John, and then I'll come back to Suzanne, Mark, and Wayne.
Thanks. So two things just want to consider. I hear so much about spending targets, agree with that, but also Christina in the beginning had brought up the other side of the equation, which is expenses. So when we're thinking about targets, as far as how this would be evaluated, I think it would be difficult, but I do think it would be important to look more at the operating margin that the practices have, as opposed to looking at just actual revenue spending and increasing in those targets and spending over years. The other thing I wanted to say is that even if we are talking about having paying appropriately for all the different services that are required to, as Steve said, create a system where we are meeting our patients' needs, having really good outcomes, I think we have to set some reasonable expectations about how that will affect another issue that is causing people either to not go into primary care or leave primary care in the first place, and that is around direct payments and parity in payment for primary care providers versus specialty care providers. I'm saying this because the expenditures that need to be done for patients, many people have been saying it, community health workers, food insecurity, housing security, all of those things that have direct influence and impact on the outcomes of our patients should be paid for, need to be covered through the lens of primary care within the concept of this. We talk about these interdisciplinary care teams all the time as a best practice for getting the best patient outcomes. But what I'm saying is if we need to invest in the primary care as a whole, we have to be mindful that we may not be meeting all the expectations that our providers have by way of having, as I said before, salaries or income that is closer to target or has more parity with our specialty colleagues.
Mm-hmm. Thank you, Laura. Laura Pellegrini, then John Hurst. Laura, go ahead.
David, thank you, and thank you for this very rich discussion. Dr. Spivak's comments about a separate primary care contractor, interesting and probably something that we would like to explore. It's something we've talked about. We haven't settled on anything. But the one point I would want to make is, given our affordability challenges with all of this, and it's obviously missing here, is this simply can't be cost additive. We feel strongly this money needs to come from other parts of the system if we're going to invest in primary care. And then really drilling down on, I guess, what the target level should be. What is really going to be transformational for primary care and really make a difference? I think we're having that discussion internally within our MAP subgroup filled with primary care physicians. And I think some of the targets, I'm not sure they think are really going to be enough to be transformational. So we should talk through that as well.
Thank you, Laura. Appreciate that. John?
Yeah, I would, David, thank you, David. I would just echo a bit what Laura said. I think whether it's a separate question, David, or it's amended into, what should the spending target be, level B, I think we have to be explicit. Otherwise, we're going to be raising a whole lot of questions in folks' minds that any target must come out of current spend in order to protect both ratepayers, premium payers, and taxpayers. I think, otherwise we're opening the door for more unaffordable spending for the premium payer and taxpayer. And I hope that's not anybody's objective in this group.
Thank you, John. And I will just say, I'm definitely not trying to avoid that question, and it is an important question that this group will need to wrestle with. These were like Chris Kohler's design questions, but yeah, you're absolutely right. How we think about this spending targets in relationship to our existing healthcare cost growth benchmark and affordability targets, we are going to have that conversation for sure. Before Suzanne, Mark, and Wayne, I want to get to you, but I just want to show this group, if we can advance, I think 3 slides. Keep going. Get to the California slide. I just wanted to just share as an example, and we can continue this conversation at our next meeting. But this is just one example of one recent state that has set a spending target. This is California. They set a 15% spending target by 2034. That's kind of their long-term aspirational. But then they also have kind of an annual incremental target that they're going to kind of be tracking year over year. They have a government organization, not unlike the HPC, Office of Healthcare Affordability, that's going to be doing the monitoring and kind of reporting on this. But I raise this not as, our proposal or not as the example we should definitely be using, but just as an example of a recent state that had done this and how they're thinking about kind of both long-term and incremental. So I'm going to leave this slide up here. We can talk more about this at the next meeting, but Suzanne, would love to get your perspectives and thoughts on this larger topic.
Thank you. And I'll be very quick because I think a lot of folks said what I was thinking as well, and also agree with the last 2 speakers around not being additive and thinking about how we shift some dollars to primary care. And Laura's point about what's transformational, I think we can also start, obviously, I think having a requirement, I agree, is the most helpful. And we want to make sure that it's tangible and something we can work towards. And maybe starting towards what's in existing legislation and think that's pending in the State House, and thinking about are those spending targets enough, and are there any tweaks that need to be made? I'm just going to quickly put my child health hat on again too, and just make the point again of thinking about making sure that pediatrics is not shortchanged in any kind of spending target that we think about if it's already at the target that we are moving towards. And that's something that I've been trying to grapple grapple with and understand how that would be incorporated into the larger target as well. And last but not least, just want to echo the comments around also working backwards a little bit of like what we'd like to see in primary care, and working back from there to see how the spending target can actually increase both access for folks, but then also transform practices in a way that has the interdisciplinary teams, as Laura said. So just want to echo a lot of those points because I think that's a good way of approaching this. Thank you.
Thank you, Suzanne. Well said. Dr. Freeberg.
Yeah, thank you. Just a couple thoughts. Just briefly on this slide, I'm not so sure California is actually not enforceable. I would talk to someone who's running that program in California. They do have a PIP mechanism in place. Just a minor detail there. But just on the main question, I wholeheartedly agree with Chris Kohler's guidance to set the spending targets not as a percentage of total medical spend at a given year, but as a rate of increase from where it currently is. And the reason for that is that we haven't yet, the CHIA work to define how we measure percent primary care spend is not done and will be updated every year. And unfortunately, you open yourself up to the possibility you define yourself all the way to the target, or at least part of the way to the target, and a way of getting away from that. And this is, I think, the real strength of the Chris Kohler approach, is to say, wherever we are now, it has to increase by 10% next year and 20% the year after that and the 30% the year after that. And what's great is as you change the definitions, you just recompute all that. It's kind of immune to definition change. It also is really good because you can say that has to apply at the practice level. So that will automatically kind of deal with the pediatrics issue, which is vulnerable if you have like an overall fixed spending target, right? So that's another potential issue. I want to add another consideration here, which is if this is going to be a mandatory target, and I think that's probably the way to go to achieve the effect people are looking for, we always have to have an eye on mental health parity federal regulations. You could easily put your plans in a position inadvertently and with good intentions of having to choose between a state mandate and a federal mandate with no mathematical way of satisfying both. That's a situation to actively avoid, because I think I don't know how that would end up. That would be a difficult one, may end up in court, and that's something definitely to avoid. Last point on this is that, and this gets to John's point, which I wholeheartedly agree with, this has to not increase healthcare costs even in year one. And that means it has to come from elsewhere in the healthcare spending pie. And this gets back to the definition of the CHIA again. And we had talked at a previous session about whether to include prescription drug costs. If prescription drug costs are not included, that will automatically mean that meeting a required primary care spending increase, you get no credit for taking money from RX. It will only give you credit if it comes from hospitals and specialists. So it's a reason to be expansive in the denominator. Thanks.
Thank you, Mark. I'll just quickly say I have been thinking about the issue of kind of like what is our starting point, and you can make some data decisions that make us look like we're starting at 6% or make us look like we're starting at 9%. And so, setting a 12% target off of 9%, you obviously don't have as far to go. So I like your urging on thinking about kind of the incremental. I will just share, I do think that there's something motivational about a longer, more aspirational target. And so, but I think your points are really well taken. Dr. Altman and then Senator Friedman, we're going to give you the final word of today's meeting.
Okay, thank you, David. Well, what's heartening is that there were 4 things that it felt like there was consensus on in the group. We all think there should be a requirement: payers and health systems, the accountable entities, Health Policy Commission and CHIA kind of enforcing it. And everybody agreed with John and Laura that we shouldn't be spending more money. And I agree from year one, Mark, right on. That's amazing. The area that we have to work on is this 12%, 15%, or ramping up by a certain percentage, as Mark said. Mark talked about this concept of defining your way all the way to the target. And if you want an example of that, Oregon did exactly that. They set a target, I believe it was 12%, and then they basically did not increase spending on primary care. They just changed the definition to get themselves to the target. So that's the perfect example of what Mark was talking about. So I think we have to put really careful thought into this. And I also agree with what David said. There's something nice about saying, let's go to 15%. If you look at OECD countries, our peer nations, they're at 15%, and they have way better outcomes than we do in the United States. So I suppose we could have our cake and eat it too by having the target, but being really careful about the definition so that it prevents us from cheating with the definition to get us to the target. A few last quick comments. Steve Martin mentioned target necessary but not sufficient. I agreed with that. He also mentioned Rhode Island. And it is interesting in Rhode Island, they were the original state to increase primary care investment. You go talk to PCPs in Rhode Island, no one's celebrating how amazing primary care is in Rhode Island. And the reason for that is because they increased primary care investment, but they didn't change the payment mechanism to a prospective monthly payment, and they didn't include ERISA plans. So the effect was really anemic. Barbara Spivak mentioned a primary care carve-out, which I think, and Laura was speaking to that as well. I think it's a brilliant idea. One way to do that is our primary care stabilization fund that is in H1370. And lastly, Laura Black was talking about the importance of primary care teams, and the transformers, as we call them, are in all three of the primary care bills that David mentioned earlier. So thanks for this great discussion.
Thank you, Dr. Altman. Senator.
Thank you. This was really good. Thank you, David. You guys did a great job. If we stop calling it primary care and start calling it family medicine, we will include everything that we've been talking about: kids, behavioral health, delivery, dying. It will all be included. And that's really what we're talking about. And I think we need to start talking it that way, because we are talking about family medicine. We're not talking about just sort of primary care. And then I would like everybody to please read all of the bills, because all of the bills are very, very clear that there will not be an addition of dollars. It will only be a shift of dollars. Okay, so nobody is pushing in any way, shape, or form to add more money to the gazillion, million, trillion dollars we already have in there. And then, while I don't believe that the answer to this is to give the money, is to make the state responsible for a primary care trust fund, we do need to add the state to the accountable entities, because they are an active player in this. And we are always going to have Medicaid, and we are always going to things are always going to shift, and the state has responsibility in ensuring that this system works. So I think they also have to be the accountable. And then finally, I have no position about 12% or 15%, but I will tell you, I should live so long that we actually have a conversation at some point where we say, well, we've reached 12%. What should we do? So I think, whatever anybody believes, it should absolutely be mandatory and well-defined what it means to get there. So thank you. Great meeting, David. Really appreciate it.
Great. Thank you, Senator. And I, just to echo the comments of the last two speakers, I do feel like we are making progress here in these conversations, that we are identifying those issues that require a little bit more work and a little bit more thinking, and that's what we're going to be doing before the next time we meet. And so that when we meet again in September, we can continue to make progress. I will just share, I think I think about our charge in this task force, and we have these very clear, specific deliverables that the legislature wants us to weigh in on. And I want to keep us on track, and we'll be so excited when we start hitting those green checkpoints. But I also want to reflect the conversation today that many of you want to have this, a larger conversation about how all of these pieces fit together towards a broader vision of better primary care. And so I will I think it would be worthwhile at our next meeting to carve out some time to think about that broader vision of how all these pieces fit together and what are we aiming towards. So the good news is our next full task force meeting, we are asking that you guys come in person. We'll host it at the HPC. We'll have coffee and snacks, I promise. But I think it will be great for us to be back in person to continue these conversations. Before then, we are having one more work group meeting before August, Wednesday, July 30th. The workforce work group, sorry, will be meeting, and that meeting will be virtual, and we'll share information on all of that. So 1201, thank you all so much. Thank you, Secretary Mahania.